I'm pleased to welcome you all to this week's Medical Grand Rounds. Next slide, please. I'm Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joe's and pleased to be hosting today. As part of our rounds and in response to our responsibilities as healthcare workers to address the calls to action of the Truth and Reconciliation Commission, we will start off with our land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And as we turn the corner into our rounds for today, I'm delighted to welcome Drs. Michelle Zeller and Andrew Shih. They are going to be presenting on the topic of albumin, pervasive use with limited evidence, what's the deal? And I'll just tell you a little bit about both of our presenters today. Dr. Michelle Zeller is an associate professor and clinical hematologist with the Division of Hematology and Thromboembolism in the Department of Medicine at McMaster and the co-director of operations, transfusion medicine for Hamilton Health Sciences. She's also the program director for the transfusion medicine area of focused competence diploma program at McMaster and a medical officer at Canadian Blood Services. Prior to joining faculty at McMaster, she completed postgraduate training programs in internal medicine, hematology, and transfusion medicine, in addition to a master's degree in health professions education. Dr. Zeller is a core member of the Michael G. DeGroote Center for Transfusion Research, where she leads and participates in clinical research on blood alternatives, such as intravenous iron, blood product utilization, informed consent, and impact of blood donor characteristics on recipient outcomes. And joining Dr. Zeller in the flesh, together in the same office, is Dr. Andrew Shih. Dr. Shih completed his medical degree at the University of Saskatchewan, internal medicine training at Western University, and hematology and transfusion medicine training at McMaster with a thesis-based master's degree in health research methodology. He's currently the regional director of transfusion medicine at the Hamilton Regional Lab Medicine Program and an associate professor at McMaster University under the Department of Pathology and Lab Medicine. He's also the current chair of the Canadian National Advisory Committee for Blood and Blood Products and a steering committee member of the Canadian Transfusion Trials Group. So we've got two highly accomplished, two extremely knowledgeable folks here to speak with us on this topic. And I'll say, as a fellow hematologist, two outstanding colleagues. So really delighted to have you both joining us today. And to share with us where we're at with the evidence in this space so we can make sure that we're following best practices in our clinical work. Over to you.
Well, thank you so much for inviting us. And it's so much fun for Andrew and I to be able to hang out together on a Thursday afternoon. I'm going to be talking about the first section. We have three sections. First of all, these are our conflicts of interest. I don't feel that any of these directly compete with the topic we'll be discussing, which is albumin today. We have three learning objectives to share with you today. The first part is to provide an overview of albumin, its manufacturing, utilization, trends, and cost. The second part, Dr. Shih is going to take over from me to describe the potential risks and drawbacks of inappropriate albumin use, and finally to interpret recent guidelines published in CHEST by one of our dear colleagues, Dr. Callum, and a big group of fabulous leaders from across Canada and internationally. And then we're going to apply them to a few common clinical scenarios and have enough time for some questions afterwards. And we are highlighting work that's been done by a lot of our amazing colleagues, and we're going to be drawing upon some of that throughout our talk and sharing some resources that were shared with us by our wonderful colleagues who've been leading these fabulous initiatives. So I'm going to take us through part one, an overview of albumin manufacturing, utilization trends, and cost. And I'd like to start with what is albumin? Well, albumin is the most abundant protein in the plasma, and it has a low serum viscosity. It is a highly soluble molecule that is negatively charged overall, but it's capable of binding both cations and anions. So this takes us way back to chemistry. It's responsible for 80% of the total plasma oncotic pressure that is important for maintaining levels of water in our circulatory system. So really important in maintaining blood pressure as well. A gram of albumin attracts 18 ml of water by its oncotic activity. So theoretically, an infusion of 25 grams of albumin would expand the plasma volume by 450 ml. This would be one of the common teaching way back in medical school where we're learning about physiology and pathophysiology. Albumin is synthesized in the liver in a healthy person at a rate of about 16 grams per day. And things like malnutrition, stress, medication, and aging can decrease production of albumin. If you lose a half a liter of blood, you could also lose 12 grams of albumin with that blood loss. There's a lovely chapter in the clinical guide to transfusion medicine available on the professional education website that is a subsidiary of Canadian Blood Services. It was written in 2018. So in terms of the indications for use, that's been updated. But in terms of what albumin is, how it's made, it's a great resource to check out if you're interested in further learning. What about transfusible albumin? So we just talked about what it does in our body and how it's made and what impacts it in our body. But what about if we want to take it from somebody else's body and put it into a patient? These are some pictures that I took in our blood bank at McMaster of two different formulations of albumin. And you can see that it's yellow. It kind of looks like apple juice, but I wouldn't recommend trying to drink it because it probably doesn't taste like apple juice. We have human-derived albumin that is available for transfusion in Canada. It is sterile. It's a latex-free solution that has a physiologic pH and a sodium concentration of between 130 and 160 millimoles. And it's produced from plasma from fractionation. And I'm going to show you what fractionation means. But basically, when you donate blood, well, I'll show you on the next slide, we can take the plasma component from blood from thousands of people and mix it together. And then from it, we can derive all kinds of things, including albumin. During this process of fractionation, the different components that are plasma derived undergo viral inactivation processes to make sure that they're sterile. And we have in Canada two concentrations. There's 5% and 25%. So 5% is isoosmotic with plasma, and it's considered to be therapeutic, for example, for plasmapheresis, so pure replacement, when you just want to switch out one with another. Whereas the 25% albumin is hyperoncotic, and it would be equivalent to a plasma volume 4 to 5-fold higher than the infused volume. So for example, we're going to talk about indications, but if you wanted, theoretically, 25% albumin would be the product of choice if the patient had an oncotic deficit. But again, we'll talk about the indications. That's the meat of today. So where does transfusible albumin come from? We can collect people's blood in two different ways, or their plasma. We can either do a whole blood collection, where we take half a liter of blood out of a person, or we can do apheresis, which is where we connect a person to a machine that takes blood out of the body, adds an anticoagulant, spins the blood, and then divides it based on its density and weight, and we can pull out layers of what we want to keep and put the rest back into a person. Whole blood, we can make red cells, platelets, and plasma, so we can obtain these different components through different ways, including through gravity to separate out these components. Or from apheresis, we can collect at Canadian Blood Services platelets and plasma, or just plasma. What about the white blood cells? We have universal leukoreduction here in Canada. So all of the components that we take have gone through additional filtration to remove white blood cells. And with the plasma that's either collected through whole blood or through apheresis, we can break it down into different things after we pool it. So we can take thousands of donations, put them together, and then break them apart. And the things that we can break apart that are plasma derived include factors that are also available as recombinant, so not human derived, but they look like human derived. We can get immune globulin or IVIG or SCIG, or we can get albumin using this fractionation process. And this is a picture from the internet of what a fractionation plant looks like, where we can take thousands of plasma donations, put it in these vats and expose the vats to different pH temperatures, and then peel away different layers that can undergo additional sterilization and viral inactivation techniques. And it's this process that gives us albumin. And again, this is a picture of our albumin shelf downstairs at McMaster, where Andrew and I are sitting right now. I wanted to highlight a little bit about Canadian Blood Services and blood transfusion for you, so that you'll have just a better understanding of the scope of Canadian Blood Services. We have just under 800,000 whole blood collections from about 400,000 active blood, plasma, and platelet donors. So it's 400,000 people who sustain our blood system for all Canadians outside of those who are provided from Quebec. We collect just under 100,000 plasma collections in addition to the plasma we derive from whole blood collections. We are not self-sufficient in it's doing this. We are not self-sufficient in the amount of plasma that we collect in order to make things like IVIG or albumin. So we have to buy additional product off the free market, often from American donors who have donated to get the stuff that we need. And I wanted to highlight this budget. So I think we're at 1.6 billion at this point for our total operating budget. And of that, 900 million-ish, give or take a few million, went towards plasma-derived proteins and other related products. That includes albumin. So that's a lot of money that we are spending of taxpayer dollars. Our blood is paid for through our taxes, through the provinces and territories, as opposed to from the hospital budget. But it does, each of us contribute to this cost for our country and for the health of our patients. If you pay taxes, that is, which I hope that you do. This is old data that is from 2022, and it was from my colleague, Dr. Jeannie Callum, who's done a ton of work spearheading these albumin initiatives. And it shows us Hamilton General, St. Joe's, and the Juravinski, just so you can get an idea of the 2019-20 and then 2020 to 2021 data. And again, you know, we did have something happen in the 2020 to the 2021 year, i.e. COVID, which really did impact some of the blood product utilization. But you can see we're not the lowest, but we're not the highest users. And you can see that Kingston General used to be a very high user, but then they underwent something called the Jeannie Callum effect, where she's brought their utilization down quite significantly with incredible work that she's done. So I just wanted you to see sort of where we're at. And here's another peer comparison data from pre-2022. And again, it just shows us the Juravinski, St. Joe's, Hamilton General. We deal with different patient populations. Not all of these hospitals may have the same patient populations, but it does give you an idea overall of sort of where we stand from an albumin 25 gram equivalent per 100 days in this particular graph. This is part deux, so our second part, where we're going to talk about potential risks and drawbacks of inappropriate albumin use. And I'm going to switch seats with Dr. C, and he's going to take over from me.
Excellent. Thank you, Mickey. So I'll go through the potential risks and drawbacks of inappropriate albumin use. And just to note, from here on out, we'll be sort of peppering in a few slides from a really nice Mythbusters slide deck that was produced by a bunch of our colleagues across the world on trying to sort of educate people on appropriate albumin utilization. So just to acknowledge that we've taken some of these resources off of profedu.ca, which is hosted by Canadian Blood Services. So the first myth is that I oftentimes hear this from folks where a lot of people will say, well, even if albumin doesn't have, a huge amount of evidence towards use in a particular clinical scenario, there's probably no risk in giving it because it tends to be safe. The amount of adverse events that occur from it tends to be quite low, and maybe it's even safer or more natural compared to crystalloid. But this was actually proven differently by many RCTs, as we'll go through, demonstrating an increased amount of pulmonary events with the use of intravenous albumin. And this has mostly come from the cardiac surgery and the cirrhosis literature. In fact, even in cardiac surgery, there are large randomized control trials that demonstrate an increase in bleeding and infections when you compare intravenous albumin to crystalloid. In addition, oftentimes, while we give albumin to increase the oncotic pressure, like Mickey has stated, we also have to recognize that the manufacturing process may also impact its normal function. So it wouldn't be quite as functional as de novo albumin that's produced in patients. And as Mickey also suggested, another myth is that albumin is not very costly since we get it from free donations. But a lot of the times, there's a fractionation process, and because we're not self-sufficient, we have to purchase a lot of the albumin that we use from other parts of the world. So albumin is actually much more expensive than crystalloids, and contributes greatly to our overall blood budget. And it tends to be manufactured from large volumes of plasma and is also quite expensive, where even the acquisition cost is likely a fraction of the total healthcare expenditure, including sort of the infusion of it as well. And just to note, even for 5% albumin that's given up to 5 mils per minute for a 60 kilogram person, a 48-hour infusion of 5% running at 1 mil per kilogram per hour is about $3,000, which is fairly significant. So why should you care? So we know, and we'll go through some of the literature, which is quite varied, that demonstrates, that probably explains why albumin utilization in many jurisdictions, and including a lot of Canadian studies, is quite varied, and doesn't necessarily have a high degree of appropriateness. And I think it's because a lot of people, there's a lot of mystery in terms of the evidence base around albumin. And as noted before, it's reflected in the cost that's unnecessary and doesn't contribute to better patient outcomes. And I think something that's very underappreciated is the risks to the patient when you do use albumin. We know with the higher oncotic pressure that we use for albumin when it's used as a resuscitation fluid, as an example, greatly contributes to transfusion-associated circulatory overload, even when you compare it to crystalloid. In addition, albumin also, when it's produced, can produce hypotension due to sort of leftover molecules that sort of get produced, that get left over in the albumin after production. You can get anaphylactic reactions similar to any other blood product. It also, in studies, has been shown to contribute to potentially more red cell transfusions that are unnecessary. And also, you can sometimes get peripheral gangrene due to sort of hemodilution of natural anticoagulants. So lots of risks associated for what I think a lot of clinicians consider a fairly benign therapy. And this leads us into part 3, which is going into a recent set of guidelines and trying to apply them to a couple common clinical scenarios. So just as an overview, this is the International Collaboration for Transfusion Medicine guidelines that was published in CHEST this year. And even though the guideline is from the so-called International Collaboration for Transfusion Medicine guidelines, it actually included a lot of different clinical groups to help produce these guidelines, including hepatology, ICU, gastroenterology, nephrology, cardiothoracic anesthesiology, and internal medicine. And they looked at albumin versus synthetic colloids or crystalloids in a large variety of populations and look for a large variety of outcomes. And in doing this literature search up to November 2022, they found 54 eligible studies with 14 recommendations, of which 9 of them are applicable to adult populations. So this demonstrates sort of the search strategy that they did. They started with about 6,000 articles, or they eventually led down to about 600 full-text articles. And then also note that studies oftentimes didn't report adverse reactions. And then also that the guidelines, are limited to the common uses of albumin and don't address every possible patient scenario. Certainly with guidelines, there is an element that they don't necessarily apply to every single patient in front of you. But I think, after reading these guidelines, it certainly has convinced me that really we should be using albumin in more exceptional circumstances rather than routine circumstances. So here are the summary of recommendations in adult patients. So you'll see on the left side, the 2 instances in which intravenous albumin is recommended. And then on the right, you see the instances where it's not recommended. The color coding is that in green, using sort of the grade, using grade to sort of look at the quality of evidence or the certainty of evidence. Green represents moderate. The orange represents a low certainty, and red represents a very low certainty. So we'll go through, first of all, what had the moderate certainty of evidence, which is first-line volume replacement or decreased albumin in critically ill patients and cardiovascular surgery. So, and just to interweave this, there's, with the case of sepsis, we have a 74-year-old patient admitted with sepsis, hypotensive on pressors with significant anasarca and multi-organ failure, with a patient receiving already 7 liters of crystalloid. One question that might pop up is whether or not you would use albumin in this case. And really, the myth that we would like to bust here is that in sepsis, albumin should be used if additional is required following the infusion of several liters of crystalloid. In reality, if you look across multiple RCTs and systematic reviews evaluating the role of albumin in patients with sepsis, the use of albumin has not been found to associate with improved outcomes. And diving deeper, specifically for critically ill patients with hypoalbuminemia or requiring volume replacement, on the left, you have a systematic review of this question, which demonstrated maybe a better mean peak arterial pressure with albumin, but absolutely no mortality benefit, which is demonstrated in the forest plot below. The 2 big trials that have been done were the Albius trial, which was by Chironi and colleagues, and then also Finfer and colleagues below with these sort of gray boxes in the forest plot. And for the Finfer trial, which was the largest trial, which encompassed almost 7,000 patients, broadly from medical and surgical ICU settings, to give albumin in the intensive care unit, they found no difference in outcomes whatsoever. In fact, in a subgroup of traumatic brain injury, they actually found a higher mortality rate with the use of intravenous albumin. If we look at burn patients in particular, unfortunately not great evidence with this, which is why it has a lower certainty of evidence. They looked at 4 randomized controlled trials and 3 observational studies and found no difference in mortality whatsoever. However, if you take out the 2 trials that have a high risk of bias, which also happen to be the largest randomized controlled trials, there is a potential signal for albumin being associated with reduced mortality. However, I think this is quite a bit of cherry picking to kind of pull out this result. And I think in this area in particular, there needs to be greater evidence before widespread routine use. For cardiac surgery, this was another systematic review that looked at 42 different randomized control trials comparing albumin with synthetic colloids and crystalloids, and they found 15 different trials. And across the board, whether you use albumin to prime the pump, whether you use it for volume expansion, or whether or not you use it in pediatrics, they found no signal of a difference in mortality whatsoever. In fact, in the large Albix trial for cardiac surgery, they found with albumin there was a higher risk of bleeding, resternotomy, and infection. And finally, even though it's not addressed in the guidelines themselves, one thing I would like to address, since it's used often, is hepatorenal syndrome. So oftentimes albumin is used in this setting, but just to flag that all prior trials that have used albumin and hepatorenal syndrome had both albumin in the treatment and the control arm, usually with other vasoconstrictors. So it's unclear whether or not intravenous albumin is beneficial or harmful. So I would say at best the evidence here is uncertain. In terms of the summary recommendations in adult patients that are recommended, large volume paracentesis and spontaneous bacterial peritonitis are the two that are often cited and are recommended in this guideline. So if you have a case of paracentesis here with a patient with known cirrhosis presenting to clinic with worsening ascites, and the plan is to remove 3 liters of fluid, the question here is, would you consider albumin in this case? And here, we'd like to bust the myth that albumin should be given during any large volume paracentesis to prevent hypotension. So it's not routinely indicated, and really only indicated if you remove a very large volume of fluid that exceeds 5 liters. That's what the evidence tells us, and is recommended by multiple medical societies in regards to liver disease and liver transplantation. So if you're removing more than 5 liters, really then a dose of hyperoncotic albumin should be given. For other not recommended indications, there's also cirrhosis in a variety of situations, including extraperitoneal infections, hypoalbuminemia, and refractory uncomplicated ascites. So just to address cirrhosis and extraperitoneal infection, there was a well-done systematic review done a couple years ago that essentially showed no effect of intravenous albumin on mortality or kidney impairment, and actually higher rates of pulmonary edema with albumin across 3 studies. There was a higher resolution of acute on chronic liver failure with albumin, but again, that's counterbalanced against a higher risk of pulmonary edema and also no effects on mortality whatsoever. If you dig into the 2 large trials, they also show no difference in mortality or other patient important outcomes, and they only found a broad signal of maybe better reversal of hypotension with the albumin, but again, no patient important outcomes. For just cirrhosis and hypoalbuminemia, probably the most well-done trial is the ATTIRE trial, which looked at almost 800 patients and randomized them to 20% albumin versus standard of care to try to get patients to an albumin level greater than 30 grams per liter. And they found no difference whatsoever in the primary endpoint, which was a composite of infection, kidney dysfunction, or death. And you'll see on the right, they did hit the target albumin with the albumin infusions. And notably, with the table below, the incidence of pulmonary edema in the albumin group was quite a bit higher as well. So another myth we would like to bust is that low serum albumin is an appropriate indicator for albumin infusion in ICU patients. This was proven incorrect by the studies I just showed you. And in addition, the Albios trial is another trial that was done in this area that looked at almost 2,000 ICU patients randomized to daily albumin versus crystalloid, and they also found no impact on mortality, organ dysfunction, or length of hospital stay. For cirrhosis and refractory uncomplicated ascites, there are 2 sort of trials with opposite effects seen. So the ANSWER trial looked at patients who had cirrhosis and randomized them to albumin twice-daily for 2 weeks, and then for albumin weekly for up to 18 months versus no albumin. They did see a mortality difference and lower complications with the albumin arm, but I would highly caution you to overinterpret this trial. This trial had the bias in which the albumin arm got weekly visits along with the albumin infusion. So the amount of care that was given in the albumin arm was quite a bit different in the control arm. So we can probably agree that there is probably an intermix of effect, maybe potentially from albumin, but most certainly because of the higher degree of healthcare access that you had in the albumin arm. If you compare that to the mock trial, which was done in Spain, they looked at oromidodrone and albumin versus placebo. in outpatients awaiting liver transplantation, and this was masked. So like unlike the ANSWER trial, which you could know the allocation of whether or not somebody got albumin or not, in the mock trial that didn't happen, and they found no difference in outcomes whatsoever. They did find some decreased renin activity and aldosterone activity, but again, no differences in mortality or complications. So I would say because of these competing trials and the fact that they don't find a consistent signal, this should not be a routine indication for albumin. Finally, for the very low certainty of evidence indications for which albumin is not recommended, there is oftentimes a myth of using getting better diuresis with a sandwich of diuretics and 25% albumin. And largely, there have been only a couple of small RCTs to look at this question, and none of them has shown any difference with adding albumin to Lasix in improving patient-important outcomes in edematous ICU patients. You notice the citation there is from 2014, just to acknowledge that there have been 2 systematic reviews that have been done after this one, and they showed the exact same results. And then for myth number 8, that people oftentimes use albumin for intradialytic hypotension rather than crystalloid or pressors for ICU patients. And the reality is that not all intradialytic hypotension is due to intravascular volume depletion. So sometimes even with giving albumin, you're not necessarily fixing the problem. With the small trials that have been done, sometimes you get better transient hemodynamic improvements after hyperoncotic albumin. Sometimes in one trial, you get slightly better ultrafiltration rates, but there are, again, no differences in no trials that assess clinically meaningful outcomes. And so given the cost and sort of the potential downsides of albumin, again, in this indication, it's not routinely recommended, although there is an ongoing clinical trial to try to answer this question. So in conclusion, really with this guideline, the only clearly beneficial indications for albumin are in cirrhosis with spontaneous bacterial peritonitis and paracentesis that's large volume, over 5 liters. And the infographic on the left kind of demonstrates specifically the levels of evidence and potential harm for use of intravenous albumin in critically ill patients. And for a lot of the indications that you see in critically ill patients, it's either potentially harmful or the evidence base is uncertain. And in addition, we know that giving intravenous albumin, again, precipitates the risk of fluid overload, hypotension, anaphylactic reactions, and hemodilution, also leading to peripheral gangrene. One of the things is that, probably the questions for albumin utilization in therapy haven't been fully answered because across the literature, at best, there was only moderate certainty. So really, before the routine use of albumin can be further spread, there needs to be a lot more evidence to justify its widespread use. So again, that was a quick summary of the ICTMG guidelines, as well as incorporating some of the Mythbusters slide deck. You can find the guidelines by scanning the QR code on the screen, or even just searching it on PubMed. And then for the Mythbusters slide deck, you can again find that on profedu.ca. So hopefully we've kind of gone through we've given you some education in terms of where albumin can be best utilized, and hopefully, as Mickey sort of demonstrated, we can improve our utilization of albumin to try to get ourselves to something that's more appropriate and more in line with some of the lower utilization centers. So we're really hoping to get your support to really think twice before you give albumin. So with that, I'd like to thank everybody for listening in, and thank you, Madeline, for helping to organize this and giving us a chance to give our spiel on albumin.
And we're happy to answer questions from people. I also just wanted to say, I remember being an ICU resident long ago in London, And you would find out which staff was starting, Monday morning. And just before they would start, you would run around the ward and add an albumin sandwich onto every single person's order if the attending was an albumin person. And then the next Monday, you would run around and you would discontinue all of the orders if the next person coming on was not an albumin person. And I remember it dawned on me even then, there's probably a better way to practice medicine than this.
Good illustration there, Dr. Zeller, and thank you both so much for providing such a clear presentation on a topic for which we have a pretty decent amount of evidence, as you've presented across a number of potential indications. I see one hand up, and I'll just invite other attendees if you either wanted to raise a hand, and then I can provide you with the ability to unmute yourself, or if you wanted to enter any questions you may have for Drs. C and Zeller into the Q&A feature on MS Teams. Those will be our two main ways to do Q&A. And so we've got Dr. Anne Holbrook, who I'm going to allow mic. And Anne, please share with us your question.
Thanks, Madeline. And thanks for a great topic. That was really good to hear. And we have done the guidelines through ACP Journal Club. So I was aware of this, finally, this excellent, collection of indications. I think that's one of the problems for albumin. It's sort of like clinical pharmacology. It spans every field. So each individual field, maybe it's not paying quite as much attention. I just wanted to ask about the cost a bit, because for 40 years, a lot of us have been saying, I think we use too much albumin, but we're not that sure of the evidence in total and not sure of the cost, but it's a Hail Mary thing that comes up all the time. I thought I heard a bit on the cost of a 5% regimen. I might have been wrong, but I wondered about the 25%, because to be honest, on the wards for medicine, that comes up a bit more often in any unit that you think is useful. But can you give us a sort of a ballpark figure on the cost of 25%?
So albumin per 25 gram equivalent in my trusty Bloody Easy 5.1 that I keep handy on my desk and have a box of them here in my office if anybody would like one. I'd be happy to share. They're also available PDFs through OrbCon. So it lists an albumin per 25 gram equivalent of $61. And then you think about how often you're giving that out to people and how many constitute a dose and how many doses you would give to a patient in a day, in a week, if you're doing it Q8 hours or whatever it is. And then also to keep in mind, I think that's you that keeps beeping. I think it's over there. I think that what we also have to appreciate is that because we're not self-sufficient in the plasma world, the amount of plasma that we collect from Canadians and send to fractionators outside of Canada, so we don't have any fractionators on Canadian soil, they'll send us back plasma-derived proteins from Canadian source plasma, but we outstrip that supply, and then we have to buy from other people and other manufacturers, and it's source plasma from other countries, which is safe. So from a safety perspective, that's safe, but it is very costly when you're not self-sufficient to have to be buying product on an open market, and you're competing against other countries who are buying those components as well. So there's a lot of cost. And then the other cost that I don't know if we sort of mentioned that much, but being a plasma donor is a lot. So we have a multi-plasma program in Canada that has just under 1,000 donors who come in every 2 weeks religiously, and they donate their plasma to us. And then with whole blood donations, which you can make every 56 to 84 days, depending on how someone is labeled in our electronic system as male or female. That's a big commitment to come in and do that. And there's side effects to donation, right? It's not without any risk. So I would encourage all healthy people to consider being a donor and to contribute to our donor base. But if any of you are donors, you know that it's a commitment of your time, and it also puts yourself at risk. For example, iron deficiency in our whole blood donors. But every time you stick a needle, and like a big needle, into your vein, you can risk an injury, a nerve, whatever it is. And so there's that cost that we don't build into the monetary number. So I just wanted to, add that piece for consideration, so that every component that we are using that's derived from a human, there's cost that is outside of the money on the jar that, that required, that we should also take into consideration. So it should be with absolute judicious use that we're using each of these precious gifts that someone has given us.
Thank you so much. I have a quick question, and then there's a question in the Q&A. On that topic about how reliant we are on out of Canada sources of albumin and other protein products, IVIG, etc. I know this is a big topic, and I know there's some historical aspects of why it is that way. Maybe if you could comment a bit on that, and then I may be mistaken, but I thought I had heard recently that Canadian Blood Services was starting to look into bringing contracted in companies to be doing some paid for collection. And I heard a little bit of controversy in terms of pushback from, I think, particularly Hamilton Wentworth mayor and or council about this. So wonder if you can comment a bit about the historical factors that have influenced the availability of pay for donation schemes, and why Canada is in the slice of the pie where we're not really doing it.
I will try, and I hope that I don't get anything wrong. So between Andrew and I, we'll do our best. So in the 1970s and 80s, we had one of the biggest blood scandals, or the biggest health scandals of Canadian history, where from blood transfused components, people got hepatitis and HIV. And because of that, there was a commission, and it's called the Crever Commission, where every aspect of healthcare interfacing with blood systems was examined. It took many years. There were people who lost their licenses. There were people who were put in jail for certain decisions that were made that directly resulted in the harm to Canadians. And as a result, we have a number of recommendations that were made. And part of those recommendations are that donors should be, I think one of the recommendations is voluntary, and that we should have the accountabilities within Canada for our blood system, that they should start over so that we could build our trust relationship. And so in 1998, Canadian Blood Services and Hemo-Quebec were both born out of that very tragic time, devastating time in our history. And since then, all of our donors are voluntary donors. They do not get paid. They get snacks when they go to donate, but they don't get money for it. In other countries, they do have different systems. So in the States, many of the blood suppliers are voluntary, but they also have plasma, specific places that collect plasma and pay their donors to donate plasma. In Canada, there are some places where there are plasma donating centers where people are paid, but none of that plasma is going towards what is transfused on Canadian soil, to my knowledge. So Canadian Blood Services, as far as I'm aware, and maybe this has changed in the last 6 months, but the last time I looked at this, we were not buying any of the plasma from these institutes that had opened up, and they were seen in some jurisdictions like our own as potential competition. So if you could go over there and get paid for your plasma donation, why would you go to Canadian Blood Services to donate when you don't get paid for it? And I think that was one of the decisions made here locally, was to support Canadian Blood Services and the ability for us to have plasma to give to our patients who are admitted as transfusible plasma, or that would go to fractionation. And Canadian Blood Services has requested from the provinces and territories over the last, I think, 5 years, increased funding to support our plasma donation projects. Because at one point we were down to self-sufficiency of less than 15% for immune globulin, which is really scary. I know that in the States, back in, I think, Obama's reign, he put a stipulation in that at any point in time, the states could close their borders to keep blood products in the States if needed, not sourced. So if it was Canadian sourced, it goes back to Canada. But if there was some global shortage, they could keep the components for themselves, regardless of what contracts there were to send U.S. source plasma derived products out of the country. And so that was really scary. So Canadian Blood Services created a business plan to try and increase the amount of plasma that we collect. There's a lot in the media about these pieces. And to move us up to about 50% self-sufficiency for immune globulin specifically. Some of the ethics behind paying for donors versus altruistic donation. On the derived side, both components are actually safe. The albumin that we're bringing in from paid donors in the States, it's as safe as what is from our voluntary Canadian donors because of their rigorous testing, and it also undergoes additional viral inactivation. So I don't know if the safety piece, we can pull that in for the derived products. An argument could be made for fresh products. But there is this important value that we need to put on self-sufficiency, and that's why supporting our Canadian plasma programs is so important, so that we can make sure that we have enough stuff to give our patients. We have a very significant immune globulin shortage looming. I will let Andrew talk about that. But with that in mind, it's so important to support our donors, support donation, and judiciously use all the products that are derived from these donations. But Andrew, take it away. Fix what I did.
No, that I agree with everything said, and maybe just a couple minor points, and I'm doing this off the top of my memory as well. So one is that just to say, in Canada, just having voluntary donations, that's reflected in many blood suppliers across the world. And I think that largely came from, a lot of jurisdictions were similarly, dealing with their own transfusion-transmitted infections crises. So it was actually, I believe the WHO came with a recommendation that that donations should be voluntary. And most countries in the world complied, but the United States didn't, which is why you have paid donations in the United States. That's my understanding, that's one of the reasons why you have that dynamic. And then just to press on Mickey's point, certainly immune globulin, I wouldn't say, so I would say for immune globulin, there's always a threat of shortage. As stated, we're not self-sufficient. Many countries aren't, and a lot of countries do rely on the United States. And we certainly saw during the pandemic, Canada was not the only country that sort of wrestled with this issue, but during the pandemic, even other countries like the UK, Australia, they ran into the same issues of what happens if the US decides to keep all the source plasma, within the country and we can't get access to it. So there are many countries, including the ones that I just mentioned, that are coming up with their own immune globulin shortage plans should they happen.
I want to recognize also that Catherine Wiebert, Dr. Wiebert's on the call right now, and she's been very involved in a lot of the immune globulin shortage pieces. And also, I was like, we should ask Catherine if I got anything wrong. But she did send me the blueprint for greater security of immune globulins for patients, which is on blood.ca. So that is available. And Catherine, feel free to add anything else that I got wrong. I think Shu-Yan Ming is also on the call right now and also is a medical officer with Canadian Blood Services and can add any pieces. Both of these individuals who are tremendous colleagues and very knowledgeable as well on these pieces.
I'll also highlight, although I don't know if they're on the call, but just more on the expertise related to the albumin. I noticed a number of our colleagues, particularly from critical care at McMaster, who are in that space. And it looks like even though you were referencing the international collaboration for transfusion medicine guidelines, Canada was really punching above its weight with many of our colleagues from across Ontario there. So we've got a question here from Dr. Mitch Levine, and I think it really hits at the heart of the content you were sharing with us as it relates to indications for or reasons to stop using albumin. Is there any justified use for the 5% albumin? If not, why does it still exist?
So the 5%, so we didn't talk about plasmapheresis and any of the TTP pieces. Like, that wasn't something that we talked about. It's a wonderful question because we didn't talk about it really, except in that slide where I said that's where you could use it. But sometimes when we are doing plasmapheresis on a person for therapeutic benefit, so plasma exchange, taking out plasma and putting in something, the something doesn't always have to be plasma. So sometimes we take out plasma and we put in albumin. And so it would be that 5% albumin is my understanding that we would use in that situation. Most, like, we often think about plasma exchange being you take it out and you put it in and you're taking out antibodies or sick plasma and you're putting in healthy plasma, but that's not always the case. So we do substitute with albumin in certain indications. So I think that's, as far as I can conceive, that would be an indication to keep some 5% around. Andrew, are you aware of any other, or if we're reconstituting? So sometimes when we volume reduce and resuspend in albumin that would be a 5%, right? Pretty sure it's a 5%.
Yeah, and my understanding is like sometimes it's used to reconstitute some chemotherapies, although like very, very minor indication. I'll just say, I think I'll say I think that was one of the driving factors for Mickey and I to give this talk is, things that are maybe medically potentially inappropriate are always going to be supplied if there's an audience for it, if there's a buyer for it, right? So 5% albumin is always going to be continued to be produced and purchased if people still use it. And I think one thing we'd really like to push with this talk is that, from this systematic review and all the evidence underlying it, there's really not a lot of great indications for 5% albumin. So we should be, 25%. Or even 25%. And we really should be seeing its decreased utilization, which hopefully means there won't be as much need to produce it, and we can focus on other plasma protein products and maybe other better ways of using our tax dollars in our public healthcare system.
Mm-hmm. That's great. I'll just read a few of the comments that are including one related to this particular discussion from Dr. Michael Walsh. Re 5% albumin in apheresis. In many countries, crystalloid or crystalloid plus albumin are used to reduce cost in therapeutic apheresis. So while that may be seen as just a drop in the bucket of this whole albumin discussion, definitely for those of us in hematology, nephrology, some other specialties like neurology, where we are overseeing a lot of apheresis, that may be another opportunity down the line for us to have a look at utilization. I'm going to, as we near the end of our rounds here, I'll just read the couple of other comments, which are really thanks from colleagues here. As you mentioned, Dr. Catherine Wiebert in the audience, who said, thank you, Mickey and Andrew, that was excellent. And as well, Dr. Tabaki Abdelghani, thank you, Mickey and Andrew, excellent and very informative presentation. And I would echo that. So I just have one last question. This feels to me like the type of thing that we would see in a choosing wisely type campaign. I guess that's really what that Mythbusters approach really is taking. What do you think are the next steps as we see that, there's really not...
Andrew and I have plans.
Oh, okay.
Andrew and I have big plans here.
Just to summarize, if I can, there's not clear medical indication of benefit for a lot of things it's being used for. There is increased risk, net risk to the patients by having albumin versus other approaches. And there's, net expense to our healthcare system, which particularly in a publicly funded system, we all have obligation to look at cost saving measures. So tell us, what's your big plan?
So first of all, there's been a lot of efforts aimed at knowledge translation and dissemination of the ICTMG guideline. But outside of that, Andrew and I have, and Menika and Shui, we've, as the professional staff within, who are within transfusion medicine and always looking at gatekeeping, We are going to be reaching out to the different stakeholder groups once we've been able to obtain utilization from different groups. So we're just waiting on our report generations from our WellSky Data, Dovetail, and Epic, which everyone knows can sometimes take a while and be akin to sticking a fork in your eyeball and some salt in there too. So when we have our data, we're going to reach out to our different groups so that we can say to you, this is how much you're using. And then we're going to be revising our order sets to reflect the evidence. And that's why we want to, that's one of the reasons we want to reach out to the different high users, is so that we can craft the order sets in a way that reflects evidence, curtails use, but also makes them, we want to be able to ensure that the people who need the component can get the component or the product, right? But we also want to make sure that the people who maybe don't know, didn't realize, and aren't aware, aren't using this product unnecessarily. So there will be changes accompanied by additional education. But I think the first step for us is to really understand at a more granular level what our utilization looks like and who our big users are, so that we can involve them in the next steps of how our gatekeeping will look moving forward and what those order set changes will reflect. And we want to make sure that we have representation from our high users, which, off the top of my head are going to be ICU, and they're going to be, some of our wards and certain of our specialties. So we just want to make sure that we've done that. But we've got big plans to bring our utilization down.
Amazing. Looking forward to seeing the 2025 and beyond graphs in terms of utilization
Absolutely.
across our hospitals. Thank you both for taking the time and for providing such a clear overview of this important topic, and for a great discussion afterwards. And I think anybody who's keen in the audience to join the movement will probably reach out to you. I am going to just wrap things up for today with letting everybody know that Rounds will be back next week at the same time. And it will be St. Joe's IPAC Rounds with Dr. Samir Patel and Ms. Jennifer Lee presenting. The following rounds will be the HHS Teaching Medical Residents with Dr. Muath Alisa and Dr. Mahdi Darab presenting. So see you all back here, same time, same channel next week. And hope everybody has a great day and rest of their week.